Hi, now we're going to do gender specific for female. Okay, so first thing we're going to talk about is breast cancer. Breast cancer is the most common non-skin malignancy cancer among women. It's actually second to lung cancer in women, cancer-related deaths. So it's a major health problem in the United States. At present, there is really no cure. They estimate that a woman's risk of developing breast cancer is about 12% or 1 in 8. So it's pretty high. I'm sure someone has been impacted in their family or circle of friends, someone with breast cancer. Risks of developing breast cancer also increase with age. They do find that about 2 out of 3 invasive breast cancers are found in women over the age of 55. There are several types of breast cancer. You've got ductal carcinoma in situ, and then other different types of invasive cancers. The ductal carcinoma in situ is characterized by a proliferation of malignant cells inside the milk ducts without invasion of surrounding tissue. So this is not invasive. It can't metastasize, and women usually cannot die from ductal carcinoma in situ. But some of them, but not all, could develop into an invasive breast cancer if not treated. Invasives account for about 80% of all the cases, and they can be infiltrating lobular carcinoma, infiltrating ductal carcinoma, and there probably are others out there as well. We know that breast cancer is definitely genetically inherited, and it does result in a significant risk, especially if you have a primary relative who had breast cancer, like your mom. They definitely feel that about 5 to 10% of these develop because of a genetic mutation. So this population would be recommended if you have a strong family history of especially any early onset breast cancer, ovarian cancer, endometrial cancer, those kind of things, ovarian, to get tested. And remember, the test for this is the BRCA1 or the BRCA2. They are tumor suppressor genes that normally function to identify damaged DNA, and they thereby restrain abnormal cell growth. So we want to test for that because that'll tell you if you have an increased risk of developing it. Other things that put you at risk are if you're a smoker, on birth control pills, you've had no children, or your first pregnancy was after the age of 30. Obesity and also dense breast tissue can put you at risk as well. Remember that there is no significant specific cause for breast cancer. It's usually a combination of factors that increase your risk. Now, remember we talked about the BRCA gene. Some people may opt for prophylactic mastectomies. I've taken care of several women that have opted for that because of strong family history. I've even known one person who actually went for the mastectomy, bilateral mastectomy, as well as a hysterectomy, an oophorectomy, because there was such a strong tendency to develop these types of cancers in her family. So after she had her children, that's what she opted to do. And of course, a famous person that did this was Angelina Jolie that did that. Remember, this is not something that's taken lightly. It requires consultation with a genetic counselor, obviously a plastic surgeon, oncologist. It's a team focus. The nurse will play a valuable role in this process, clarifying information, providing support throughout the decision-making process. And lots of times when we talk about prophylactic, a lot of women say you're diagnosed with breast cancer in the left breast. You may opt to also have the right breast removed too, and then just go for reconstruction for both sides. So, all right. So, what kind of skin changes in the breast might you see? So, here's a question for you. Here's one. The nurse is assessing the breast in the female patient. Upon assessment, the nurse notices that the patient's breast is thick, hard, and that the skin pores are enlarged. The patient states that it thinks it looks like an orange peel. How would the nurse document the assessment findings? So what would we call that? And the answer would be peau d'orange. So this is an example of skin changes that can occur. You may also see dimpling in the breast. Remember that breast tumors are usually small, irregularly shaped, firm. They are non-tender and non-mobile. The patient may also notice increased vascularity, nipple discharge, a nipple retraction or ulceration, and they may palpate enlarged lymph nodes. Because remember, back from assessment, the enlarged lymph nodes are not normal. That's not a normal finding. Here's your definition of peau d'orange. So you know what that is. And they really do take on the look. See, this is a picture of like kind of an orange, like the texture of an orange, right? So definitely something that would warrant more diagnostic, for sure. All right, so guidelines for early detection. Now, I will say this, there's continual controversy with this, especially with mammography. You hear different things. The U.S. Preventative Task Force says mammography should start at the age of 50. The American Cancer Society says it should start at 45. And both agree that if you have a history or family history of breast cancer, it should start at the age of 40. Who knows, right? I think what we want to, as nurses, we want to have a conversation with our patients and offer them information like this, and then offer them the tools to discuss with their healthcare provider who's going to be ordering the exams. I think that's real important. I know for myself, my mother had breast cancer. She died at the age of 58. So it was early onset. So I was pretty paranoid. I started mammography in my 30s because I wanted to have a good baseline before my breasts started changing and getting, before childbirth, all that kind of stuff. So to make sure that things were, that we had a good history going. And they knew what my breasts looked like so they could detect changes. The other thing we would teach our patient is about self-breast exam. And usually the younger, like the teenage group, because their breasts are just developing, they tend to be a little more cystic, I guess. Lots of times the pediatricians won't teach this. Not all of them, but some won't. But definitely what we want the take-home point is they should have a clinical breast exam by a healthcare provider. In the age group from 20 to 39, it should be every 3 years. And then when you hit the age of 40, you need to have it done every year. So every time you're going for your annual exam, your physical, you should have a clinical breast exam as well. Definitely still want to teach self-breast exams. I know for myself, that's how my mother found hers. She knew her breasts, and she went in, the doctor's like, oh, it's nothing. And she said, no, it's something, it's different. And lo and behold, it was. So you definitely want to listen to your patients. I think that's crucial. Just a little cartoon, a little humor. All right, so here is a question for you, a critical thinking exercise. Your client is a mother of 3 young children. She's been diagnosed with stage 3 breast cancer and is distraught. Think about it, how scary that is. Which of the following statements best communicates the spirit of hopefulness, oh my gosh, that would be horrible, hopefulness to your client? Which one do you think will? Helping a client to find a reason to live and look forward to events promotes positive attitudes and ability to live for the moment, which in turn communicates a spirit of hopefulness. The statement we don't want to cause false hope. We don't want to induce false hope. We also, although the client may choose in another medical opinion, she needs to come to that decision with the nurse's advice. And the last response conveys false hope. Nurse and client should not confuse hope with unrealistic expectations. Okay? So the first answer, A, would be the best choice right now. And also, when we think we offer like a second opinion, that could also lead to the patient thinking that their diagnosis is inaccurate. So that's not something we don't want to go there. Okay, so when we talk about like favorable findings for prognosis for breast cancer, like if they get tumors back or diagnostics, this is some of the terminology that you may see that would explain or tell us that the prognosis is going to be better. One would be tumors that are less than 1 centimeter, negative lymph node involvement, estrogen receptors and progesterone receptors, proteins are noted, well differentiated tumors, low expression as the ERBB2, which means it's not putting out that, and no vascular lymphatic invasion. Those are all positive signs, favorable signs. Remember, breast biopsies can be done a couple different ways. You can have a fine needle biopsy. You can have a core needle biopsy. Though both of those are done by a surgeon. You can have a stereostatic core biopsy that's done by a radiologist. You can have an ultrasound-guided core biopsy, also done by a radiologist. MRI-guided core biopsy, done by the radiologist. And then excisional or incisional biopsies, and that's done by the surgeon. So there are a couple of different options, and depending on what's going on with your patient will determine which one's going to be done. Surgery is usually the choice. Either they can be a lumpectomy, partial mastectomy, a total mastectomy, a modified radical mastectomy, which means the lymph nodes and the muscles are removed. And then after this following is reconstruction. Now, adjuvant therapy will be used as well to decrease the risk of reoccurrence. This is usually like hormone therapy, something like tamoxifen, or it could also be chemo and or radiation therapy would also be indicated. They try when they do a sentinel lymph node biopsy to get that sentinel node because they're trying to determine the involvement of what's going on with this patient. One of the complications that could occur after mastectomy is lymphedema if the left breast removed, lymphedema would occur on the left side. This is because there's been a lack of development of collateral circulation after the mastectomy. And we'll talk a little bit later about ways to try to prevent this from occurring. So here's a question for you guys. Within what time frame is collateral circulation developed in a woman after mastectomy? Is it 1, 2, 3, or 4 weeks? And the answer would be 4 weeks. After a mastectomy, the patient is prescribed to do arm exercises. This facilitates the development of collateral circulation and decreases lymphedema. Examples of the arm exercises they might be doing is squeezing a rubber ball, elbow flexion and extension, hand wall climbing to increase back to full range of motion. Now the hand wall climbing means that they put their fingers on the wall, they stand arm's distance from the wall, and they start from a low position and they literally just climb up the wall with their fingers and try to get up to the point where the highest point that they can get. They should avoid wearing constrictive clothing, and they should prevent injury to that extremity as well. What should be included in the education plan for a patient who had an axillary lymph node dissection? Select all that apply. So look down the list and see what you think should happen for this patient. So we definitely want them to avoid blood pressures, injections, and blood draws in the affected extremity. Want them to wear gloves for gardening because this is going to prevent injuries. Avoid lifting objects greater than 5 to 10 pounds. Patients should not cut their cuticles because remember that could run the risk of infection. And also when they're shaving their armpits, use an electric razor rather than a regular razor. Now breast reconstruction will happen. And they can happen a couple different ways. One is a tissue expander followed by a permanent implant. So what they do is they put in a kind of like a saline balloon in there, and they gradually inject saline in there to stretch out the tissue. And then eventually they'll put an implant in there. The other way they can do it is kind of a little bit, I guess, sort of more naturally, a flat breast reconstruction. A friend of mine had this done where they actually took belly fat, which she was happy about. Not that she didn't really want to be here, but they took belly fat and then put that in the breast area. So that helped, from what she says, that it feels a little more natural. So other things to import for whenever they have this, we want to teach them about incision care, drain care. After mastectomy, they can have a drain upwards of 1 to 3 weeks. So they need to know what to do about that. They should avoid placing their arm in a dependent position. And they should call the medical doctor immediately if they have any numbness, tingling, pain, development of fever, or decreased function in that extremity. All right, so another female type disorder that can happen is endometriosis. Usually symptoms of dysmenorrhea, pelvic pain, and can lead to infertility because they have the scarring that builds up and prevents the implantation of the eggs. Lots of times this will require surgery. If the endometriosis is so significantly bad, they actually might end up with a hysterectomy as a result. Another thing we're going to talk about is cervical cancer. This is why we get our pap smears every year to check cells and make sure there's no abnormal cells. Remember, you have the vaccine now for the HPV because we know that increases the chances. Hi guys, I'm gonna go continue on. Okay, so we were talking about colon biopsies for cervical cancer. And here's a test question for you guys to go through. I guess you really can't. Let me try to fix it for you so you can see it a little better. Okay. I guess you still, well, I will post it in a different color, I guess. Let's change the black so it'll stand out for you guys. Okay. All right. So moving on. All right. So let's look at this question. Which of the following statements made by the patient demonstrate the patient undergoing a colon biopsy understands the discharge instructions? So what do you think it is? Is it A, B, C, or D? And the answer would be D. I will use a menstrual pad to capture the moisture as my cervix unfreezes. Remember, if they have this or a biopsy done, or even a more intensive surgical procedure where they actually scrape the cells off, they should always report any heavy vaginal bleeding, fever, or foul smell coming from the vagina. They should avoid heavy lifting, take showers, and they should not use tampons. Sometimes, because of cervical cancer or even endometrial cancer used as an adjuvant therapy, radiation is indicated. If the one of the takeaways I really want you to understand this is if the radiation therapy is delivered inside, like they put something implantable into the patient, activity has to be restricted to avoid dislodgement. So that puts the person at risk for DVT, those kind of things. And remember, this could be used in the case of cervical cancer, or it could be used in endometrial cancer as an adjuvant therapy after the hysterectomy. All right, the nurse is caring for a patient after hysterectomy. The patient presents with increased heart rate, decreased blood pressure, weak pedal pulses, and decreased urine output. Which complication of the hysterectomy should the nurse be concerned with? It is A, B, C, or D? And the answer would be B, hemorrhage. Remember, signs of hemorrhage will be decreased cardiac output, which will lead to decreased blood pressure, increased heart rate, because the heart's trying to compensate for that loss of blood, weak pulses, and decreased urine output. The venous thromboembolism would cause leg pain, redness, warmth, and edema. Bladder dysfunction would be indicated by abdominal discomfort and the decreased urinary output. Hypotension and decreased pedal pulses are not a sign of pain. Here's another question for you. Following after an abdominal hysterectomy, this patient, which would be the nurse will monitor for the following major postoperative complications. This is a select all that applies, so remember, take each individual one as a true or false. Which one would be potential? So what do you think it is? How many of them are potential postoperative complications for an abdominal hysterectomy? So we know that DVT, bladder dysfunction, infection, and hemorrhage. All right, a couple things about hysterectomy, just so you know, that I want you to be aware of, is definitely be aware of the bladder dysfunction. How are you going to assess for that? How are you going to, you're going to palpate the bladder, you're going to ask for discomfort. The other thing is, sometimes what they'll do initially after surgery is they will not completely empty their bladder. So say we take the catheter out. Initially they'll have a catheter. We take the catheter out and they're voiding small, frequent amounts. You probably want to check that bladder out to make sure it's fully emptied, because they may not be completely emptying that bladder. We may have to straight cath that patient. The other thing is, one thing you'll see lots of times whenever we discontinue a urinary catheter, it'll say due to void in 8 hours. So if I discontinue that catheter at 8 a.m. in the morning, if that patient hasn't voided by 5 o'clock that night, most likely I'm going to try everything I can before I reintroduce a catheter into this person. You know, running warm water, putting their hand in water, getting them to sit on the toilet, you know, things just to encourage urination. But if that doesn't work, then they're going to be straight cath or maybe another catheter longer term. So just so you're aware of that terminology that's out there. All right. Thank you guys.